Hello, everyone. Welcome to Ask an Expert. We have Dianna Milewicz here today. Thank you for joining us at the Murder Foundation. I hope that my audio is doing okay for everyone. In the chat, let us know. But we had a lot of questions after Dr. Milewicz's presentation last week that were really great. We want to dig into them today. If you have new questions, please feel to write them in the chat. Dr. Milewicz, of course, is a geneticist, PhD, and MD researcher who has spent her career studying thoracic aortic disease, so she's super knowledgeable on all those topics. So go view her presentation from last week on our YouTube channel if you didn't get a chance to join. And otherwise, we'll just jump in and get started on some of the ones that people wrote into us. So we have a lot of good things here. We have a lot of people who are asking about variants of uncertain significance, or VUSs, as many people are familiar with. Can you explain to us what it means if you get that result back, and what's the future like after that? What might be the course of action depending on what that result is?
So when we sequence the genes that cause aortic disease, we find three types of rare variants. We're looking for rare variants because we know these changes have a high impact in that they confer a high risk for thoracic aortic disease. And so we don't expect them to be found in the general population at a very high level. So we're looking for rare variants. And we know throughout the genome that whatever gene we go to, whether it's the genes for aortic disease or the BRCA1 and 2 genes or the genes for muscular dystrophy, that we have variants that definitely cause disease. And those used to be called mutations, but now the term they're using is pathogenic variants or likely pathogenic variants. I think that was felt that people didn't like to hear that they had a mutation. And so we're trying to use a term that perhaps people are more comfortable with. But then there's other variants where, and then there's other rare variants where we can say this definitely does not cause disease. And then there's a lot of variants where we just don't have enough data yet to figure out if they cause disease or not. And those are called variants of unknown significance. So they can go one of two ways. They can go three ways. They can be benign, where they don't cause disease, and we figure that out over time. They can end up being pathogenic and definitely cause disease. But we recently figured out that some of the variants do cause disease, but they're not as big of a hit as one of those mutations or pathogenic variants. And what they will do is increase the risk for somebody to have the disease a little bit, but it can be passed through generations and nobody has the disease until they have a second hit, like hypertension, or somebody's using crack cocaine or some other risk factor for aortic disease. And then suddenly that variant plus the other risk factor will end up triggering disease. So it's just going to take us a long time, most likely, to figure out a better way to classify those VUSs into one of the three bins. And then from there, we're collecting data to make sure that we know how to manage the disease, whether it's a highly penetrant disease causing variant, a pathogenic or mutation, or whether it's one of these genes that is there, but you sort of need a second hit to have the disease. Mm-hmm. And then we need to figure out what that second hit is. I think in most cases, that'll be hypertension or anything that increases the how hard your heart is beating and how much the blood flow is hitting the aorta. And then we'll have ways to figure out how to block that second risk factor. Yeah, so I think of these, variants that trigger disease only when they're in a certain situation. Is that sort of like the story with deep venous thrombosis, DVTs, where people get clots in their legs. And those clots can cause a pulmonary emboli and also cause, very severe problems and sudden death. And, most people can ride on an airplane for 12 hours and not worry about a DVT. But if few people have these rare genetic variants in different genes, and most of the time it doesn't cause any problem, and it causes them to clot faster than everybody else. So in some ways it's good, because if they cut themselves, they'll clot faster. But then you put them into an environment where they're immobile and dehydrated, not getting enough water, and suddenly they're that one person out of thousands of people that'll throw a DVT after riding on a plane and have a pulmonary emboli. So in that case, you've got the genetic variants plus this, immobility and dehydration causing the thrombosis in the leg. And I think that we really need to go after those variants that interact with environmental insults. And if we had all those variants, we would be able to not only figure out who's at risk in families where it runs in disease, but hopefully figure out those people in the general population who are just suddenly showing up with dissections when nobody else in their family had it. Then those are probably what's going on in those individuals. It's like those DVTs. Does that make sense?
I think the DVT analogy was great. So along those same lines, and this comes up again and again, we hear from people who said, I had genetic testing, or my spouse did, my brother did, it was negative, so it's not genetic. So that's a myth that we kind of want to bust here today. So can you give us an explanation of why that's maybe not the right way to think about it, and what you should instead think if perhaps someone pretty young, maybe in their 30s, had a dissection, but still had negative genetic testing? What can we interpret from those results?
Yeah, I hopefully went through some of this with my talk last time. The disease can run in families, and once you have two people in the family with thoracic aortic disease, we consider that to be a heritable or familial case of the disease. And that means that other people in the family are at risk. And the easiest way to figure out who else is at risk is to do the genetic testing and sequence all the genes that we know cause aortic disease. And if that comes back positive, then we can go through the family and figure out who's at risk and who needs to be followed and monitored and so on. If it comes back negative, it doesn't change the fact that it's a familial disease. It just means we haven't found the gene yet. We can solve in families where we know it's running in the family, we can only solve about 30% of them or less. And so we still have a long ways to go. And what we do in those families is everybody who's at risk for the disease, we bring them in, image their aorta, and look for enlargement. We know the majority of people that have an aortic dissection have those aneurysms or enlargement of their aorta before they have the dissection. And that enlargement tends to be totally asymptomatic, so people don't know they have it. And suddenly the dissection catches up with them. So once we know that aneurysms or dissections are running in the family, we can prevent the dissections in other family members, whether we find the gene or not, through the imaging. And John Ritter's family is an example of that. His family members undergoing routine imaging just to make sure they don't develop an aneurysm, so that they don't end up with the dissection.
Hi, we are very lucky to have another visitor with us today, Amy Yazbek, who is, of course, the founder of the John Ritter Foundation and the board.
Hi, guys. I even threw on a jacket. I knew Dr. Milewicz would be rocking one. Yes, I've been driving people to the polls all day, election out here in California. Dr. Milewicz, that example, that's very clear how you just said that about the families, and we are a family, and our CEO Meredith's family, there's plenty of families we know that we know it's genetic, because John died of a dissected aneurysm, because there was an aneurysm there. And Tom Ritter, his younger brother, a couple years later, I didn't know if you guys told the story, but a couple years later, was found to have an aneurysm. And he was found because Dr. Milewicz, when John passed away and I found her, we found each other, her first recommendation was everyone gets, all the first degree relatives get imaged, have imaging, so they're not in line, they're going to be the next one. To make sure no one had an aneurysm that was about to go dissect. No one was at that time. And then several years later, only 4 years later, actually, I think it was, Tom Ritter, for something else, was about to have a procedure, and we said, let's do the echocardiogram before he does it, because it was a bit of an invasive, it was a thing to look for stroke. He has cerebral palsy. And an aneurysm was found, and then we knew kind of for sure that it was, and he's fine, and he had an operation to replace that part of his aorta, so it can't dissect there because it's not material that can dissect. He's bionic right there, which is great. But everybody else that's still in the study, the gene has not been identified yet, but way more likely. And they also think his dad maybe Tex Ritter. It came from that side of the family. There were some relatives on that side, cousins, that were suspected to have it. And he died of what was put into which it is a lot, cardiac category, because his father died late 60s, I think it was, in his late 60s, grabbed his chest, died. And so in those days, and still sadly sometimes, a lot of times here, they don't question it, they say heart attack. And so we'll never know that. But going forward with John's kids and his grandkids, everybody's going to get tested at least once a year. I don't know if that is the recommendation still, Diana. By tested, I mean image, like echo.
Yeah, we, depending on the age, we go between 1 and 3 years, and the repeating.
Okay, between 1 and 3 years. And we're lucky to be able to do it once a year. And sometimes it's hard for people to do that. I've got it, and it's echocardiogram. But if anybody was going to, God forbid, run a marathon or do anything or start something
Thinking
new,
about getting pregnant, that's a big one.
I promise I won't. Just kidding.
But if somebody's if somebody has a parent that died of a dissection and they're thinking about
absolutely. And my daughter, my stepdaughter Carly, was an example. Checked in with her doctor the whole time. Diet, made sure that everything was okay, and that the doctor just didn't say, okay, got it, yeah, because they had just not heard of it before, but went, let me get into this. Delved deeply into the website. Diana wrote a letter, I wrote a letter, and Carly brought it with her for all 3 babies, and all are fine.
Okay.
And Dr. Milewicz, your research is trying to answer some of these questions, right, about finding these other, or identifying these other genes.
Oh, yeah. So if you have a family history of this disease and the genetic testing came back negative, please contact us. I think we can put
because our family's negative as of even
address in
negative
the chat here, I think, maybe
Yeah.
to contact her. And if someone had genetic testing maybe 2010, it's possible that today they might want to check back in with the doctor or genetic counselor who did that testing to see if it's appropriate to test for any other genes that have been identified since that time.
Yeah. So
Can I ask a question? That's a question that I guess asked all the time. You too. And so let me just ask it this way, and then I will hop off here. I had to jump in for when you were literally talking about exactly what my family. So my brother-in-law Tommy, John's brother, who had an aortic aneurysm and was prevented, he literally has a negative test right now for genetic, as do everybody in our family, because there's no gene that has been so far identified. But because our family's in your study, because in your study, if one is identified, the people that have spit would be contacted and only the ones that come up positive, their kids then would be at a higher risk,
Correct.
at risk.
Correct.
Okay.
So,
All right.
very good.
Okay.
You
So we
can
have-
say, I mean,
When you ever call me or write me, just go, just checking in. Don't lead with that. Actually, we would be thrilled to know. Okay, bye. See ya. I'll be on here if you need me. You can summon me like a
Okay.
bat signal.
We have some questions
Bye.
in the chat. So one is asking about a gene that was found by you in your laboratory, PRKG1. So someone has written in to ask about ongoing research on this gene, and they wrote it's linked to aortic pathology, but maybe you could just talk a little bit about that condition, since it seems like we might have some family members with PRKG1 mutations.
yes, hi. I hope you're in our research, because we really need to know to help to better manage the disease associated with PRKG1 and the one variant in the gene that actually causes disease. We have some data coming out in the Journal of the American College of Cardiology. This is the major cardiovascular journal for the US. And it's on the age of onset, the type of presentations, and type of dissections that patients with PRKG1 have. And what we know is a little bit makes it difficult to know how to manage the families, because the majority of people still present with dissections, either type A or type B. And the type A dissections, those are the ones that involve the ascending aorta, can occur with little to no enlargement of the aorta. So we've even gone in and repaired completely normal aortas in people that carry the PRKG1 variant. And this is something that we are, once this paper is published, we'll probably communicate to the people that are in our study that they should, if they carry the variant, they should think about going ahead and having even their normal aorta repaired. And the other thing we are trying to do, we just got a very, very large grant funded where we're going to really study this variant and try to figure out what's triggering dissections. We only have 2 medications for thoracic aortic disease, beta blockers and losartan. We do have some data that beta blockers do block dissections. So we're recommending people that are at risk for dissections, especially with little to no enlargement, to be on a beta blocker. Now, losartan will block aneurysm formation, but we have no data that it actually blocks those dissections. Mm-hmm. So that's why we choose beta blockers over losartan. But we still, beta blockers do not prevent all dissections, and we have to do better. And so that we have a very large collaborative international study starting in January to really look at this question. And like I said, we're going to use that PRKG1 gene as a model system to really understand what triggers the dissections. Because even in the mice, when we engineer that variant in, the mice dissect with no enlargement of their aorta. So we...
Can I ask a beta blocker question
Yeah.
real quick? Beta blocker, from what in the old days before I had one thought of aneurysm in my head, was for stage fright. It was what classical violinists, when they would, instead of having a panic attack. So it is a blood pressure, heart rate. What does, aside from what?
It does not work on the aorta, it works elsewhere.
Right.
And its primary location that most of the beta blockers work on is in the heart. And it slows the number of times the heart beats. So on a beta blocker, your heart rate should slow down, and it decreases the force that it beats to. So it does down the blood pressure.
So the force of the blood pumping. So if it was, it's less likely to have a injury.
Right, exactly. That's the idea behind it.
One quick question. So beta blocker.
Do you want? We've known about beta blockers block dissection since the 1950s. Do you want to?
Is that right?
Yeah.
So it was probably it was probably the offshoot, the off-label thing was, oh, and violinists can take it so they don't tremble when they
Well,
do
it's known to have that calming effect because
how does, I won't get too deep into the weeds on this, but I'll call you and ask you all these questions off for some reason. But does it have to do with adrenaline and being not being able to access your body, not be able to access that adrenaline, or making it not work as efficiently?
Yeah. So yeah, no,
Right.
doctors take
Right.
it
So
if they get nervous before a talk. Actually, seen doctors pass out on the podium because they took too much beta blocker. Yeah.
Really? Can you please send me? I would like to, for TikTok, just make a compilation of doctors passing out from beta blockers.
I've only seen one.
But losartan is still not proven enough to do anything. And that was something that was trying to work on the actual aorta,
Yes.
right? Not the blood force. Okay.
But it also decreases
right.
the blood pressure too.
Okay. All right. So meditation might help a little too.
Yeah, probably.
Definitely. That's a good point. Do some meditation sessions.
So the PRKG1 dissection or discussion is a great segue to another question we have, which is it possible to dissect without an aneurysm? And I also had someone write into me personally and say that they had a dissection and they did not have an aneurysm. What does that mean? Does it mean it's not genetic?
It means that it can be genetic or can be or have when it could be a case where they have a strong genetic risk or a low genetic risk. But it does happen. If you look at the current data that we have, it's probably only about 10% of dissections occur with the normal aorta, but they do occur. And what happens in families is it tends to be somewhat consistent as to this, how far we can watch the aorta grow before a dissection occurs. So with Marfan syndrome, we can watch it grow to about twice its normal size, up to about 5.5 centimeters. And people with Marfan syndrome, by and large, will not dissect. But then when you start looking at other genes like PRKG1, they can have dissections with little to no enlargement. And we know a few other genes where that happens also. So we're still trying to sort through all of this and get this figured out so we can have very specific guidelines in terms of if you have a gene mutation, how to manage it to prevent dissections. The biggest problem is in families where we don't know the gene yet. And in that case, we have to go back and say, number one, what size was the aorta when it dissected? And number two, if people in the family had aneurysm repair, what size was the aorta when the aneurysm repair happened? So if you had a father that had an aneurysm that was discovered when it was 6.5 centimeters and went to repair, then you're sitting at 4.5. Your risk for having a dissection at 4.5, it most likely is pretty low. You still have to watch your blood pressure and make sure you're not out there lifting really heavy weights or taking methamphetamines or getting pregnant. But by and large, we're probably safe to watch your aorta grow to 5 centimeters before we go in and repair it. Mm-hmm. We always need to balance the risk for dissection with the risk for aortic repair, which is, if you go to a center that does a lot of aortic repairs, that risk with the surgery is extremely low. But it's not the same if you go to a hospital that does less than 20 repairs a year. Then the rate of having complications or even death with the surgery starts creeping up. So if you do need your aneurysm repair, I would strongly encourage you to go someplace where they do a lot of aneurysm repair. It's a technical procedure.
Yeah.
And the surgeons that do it are just amazing, really amazing.
And if you want more info on that, do check out Dr. Estrera's webinar with us from April, which is on the YouTube channel and the website. He talked a lot about a relationship with a surgeon, what you should ask ahead of time, what you have a right to know from them, and what makes a good surgical patient relationship. So please check out his advice on that, because he is one of the greats and has lots of experience about how to go about making that decision. Okay, and someone follow-up asked about type B dissections or descending dissections, and do those get to the same size as the other type before they dissect, which I think is a great follow-up point.
Yeah, so the type B, the dissections occur where the blood goes into the wall of the aorta only occur at 2 locations, and that's called type A and type B dissections. The type A start right above the heart and go into the aortic wall there, and they are the type of dissections that are more deadly. But the type B dissections, the aorta comes up like a candy cane and then goes down your back, and they start right where the aorta makes a turn to go down the back. And there tends to not be much enlargement at all of the aorta. So we really have a hard time predicting who's going to have a type B dissection and who's not. Your underlying gene that you have altered in a family causing disease, if you know your gene, we can tell you what your risk is for a type A, for a type B dissection. So for some genes like PRKJ1 and ACTA2, the risk is higher than it is for FBN1 or some of the TGFBR1 LDS genes. And but we don't have a way to predict who's going to be at risk. So once again, it really emphasizes that you need to be on beta blockers to prevent both type A and type B dissections. And we need better drugs to prevent dissections. And then finally, the type B dissections are less deadly, but still, if you have one and you go to your local hospital and a community hospital and they make the diagnosis, you should be transferred to a tertiary care center, even if you're not having any complications, and especially if you have a family history of dissections. Because we know people with Marfan syndrome have a higher risk of complications with type B dissections. So we sort of extend that to all people with familial disease, whether you know your mutation or not, that you may be at a higher risk to have complications. So with the type B dissections, what they will do is they'll come in and you'll come in and image you. You will be imaged to make the diagnosis. If you have no complications, they put you in the ICU for a few days to monitor your blood pressure, and then watch you get to good control of your blood pressure and send you home. And you will come back for future imaging to make sure everything's okay. If there's a complication, right now they are tending to use stent grafts, which means they don't have to do open surgery. They can put the graft into the aorta through a catheter. And so those procedures have gotten very good in terms of handling complications with stent grafts. So it's not for type A dissections, those ones that involve the first part of the aorta, they uniformly have to do open heart surgery. So it's a much bigger procedure than the stent graft placement through a catheter. I don't know, did Dr. Strayer talk about all that?
He briefly touched on those measures, as did Dr. Eleftheriades in our very first one in April. So you can check those out, but we will have a vascular surgeon on later this year to specifically talk about those procedures and options for those of you who are living with type B dissections or living with a continued dissection that was a type A that is in your descending aorta. So we can learn a little bit about that from one of those experts.
One thing that's really important is after a type A and a type B dissection that you follow your physician's recommendations in terms of routine imaging of your aorta. Once again, you can feel completely normal, and it may be that that part of the, when they repair with the type B dissection, the dissection's there. By and large, your entire descending aorta has been torn apart, and it can cause complications, and you don't feel anything until the aorta actually ruptures. So you have to follow the recommendations for imaging. A type A dissection, most of the times it goes all the way up and then goes all the way down the aorta. And they go in and fix the first part, but then you're just like somebody with the type B dissection. You have that dissection that goes down, and we have to watch it because the aorta does start to enlarge, and the bigger it gets, the bigger there is a risk for rupture. And so we have to monitor that, because now we can go in and repair that. It used to be that everybody, we'd have to open them up, but now we can use stent grafts to repair the descending aorta, even 10 years after the dissection if it starts enlarging. And there's actually some studies that are putting a stent grafts in everybody. There's some research where they're putting stent grafts in everybody with a type B dissection to see if the outcome is better. If they just do it prophylactically at the very beginning, do they actually do better long term? Which is a really interesting question. Yeah.
Yeah, that's important. I'm going to skip to the most recent one because it's directly a follow-up to this. And someone said, I was told by my specialist that stent shouldn't be done on someone with familial aortic disease. Do you agree?
For some of the so for Marfan syndrome, I agree. For the TGF-beta genes, we have limited data, but I agree for those. For the other genes and the familial cases without an identified gene, we don't have enough data. And so I think that if you're young and you have familial disease, that you need to really discuss with your physician as to whether they do the surgery or they try the stent grafts. We know even with Marfan syndrome and some of the Loeys-Dietz syndrome genes that we can put stent grafts in and they last for a while. So if you have sudden onset of pain after a type B dissection and you go to the emergency room and you have Marfan syndrome and you've ruptured your aorta, they're going to put a stent graft in right away to block that rupture to save your life. But then they'll come back a few weeks later and do the open repair. So for emergencies, they're using it for everybody, which is saving lives. And then it's just a question of putting it in if you have an aneurysm, and is that dependent on the gene? And we're actually looking at that right now, as part of our studies in individuals that have a mutation in a known gene. And then we hope to go back and look at all our families after we have this data. So look for that data coming out in the next year if you have PRKG1 or ACTA2 or TGFB or 1 or 2 or LOX or MYLK. I'll stop.
I have a variant, one of those genes. Email Dr. Milewicz's group, mac@uth.tmc.edu. Someone will put it in the chat, and they will connect you with the right study to make sure that you're enrolled in those
yeah, it's good to be enrolled, and you can even throw out questions because like the dissection data and descending dissections with different genes, we're putting that together now. And most of you know that we put the data together, analyze it. We have to write the paper. We have to get it submitted, and all that takes about a year. But if you have questions, just go ahead and email Mac, and any data we have that we are sure about, then we'll provide it to you before publication. We're here to save lives. We're here to make sure everybody gets the correct information.
Wonderful. That is quite the incentive. Okay, getting back in order, and this talks a little bit about this gene-specific management you're talking about. You mentioned, we talked about risk of stroke last time at your presentation and how some specific changes, variants, and specific genes have an increased risk of that. And this question seems kind of general. asking about why is that true for some genes but not others, or one mutation but not the other? What's the connection between the stroke, and they also say seizure here. I'm wondering if that's specific to this person's medical history, but which I think is a question people struggle with. They might say, I know someone else who has it in their family and they have XYZ happening, but it's different in mine. Why don't we all have the same disease? Why is it different?
Well, you would all have the same disease if thoracic aortic disease is running in your family. You have a genetic predisposition for thoracic aortic disease, which we call heritable thoracic aortic disease. So that's a big umbrella that covers everything from Marfan syndrome to PRKG1 and ACTA2 and so on. So the thing is, when you go from gene to gene, there's other associated features that may be unique to that condition or grouped together with other genes, like Marfan syndrome, the gene's EPN1, and I can walk through a crowd and pick out somebody with Marfan syndrome just by looking at them because of their tall stature and long arms and legs. But I cannot pick out an ACTA2 patient. And interestingly enough, although all the TGF-beta genes are called Loeys-Dietz syndrome, the vast majority of people with those genes cannot be picked out in a crowd either. So, but then when you go from gene to gene, the complications of other vascular disease can change from gene to gene. So with, let's say, TGFBR2, one of those Loeys-Dietz syndrome genes, most of them present with aneurysms or dissections. Mm-hmm. And if they get that repaired, they will go on to have aneurysms. A subset of them will go on to have aneurysms and dissections of other arteries in their body, like in their brain, in their and the arteries to their gut, in the arteries to their legs. And so we know we have to image for those other problems. But with an ACTA2 patient, they tend not to have aneurysms and dissections of other arteries, but instead some of them will have the arteries going to their brain blocked in a specific pattern that leads to strokes. And those strokes can occur at a very young age. And so once again, we hope to have better drugs and better ways to prevent those strokes in patients with ACTA2. So why does it all change between gene to gene? I think it's fascinating. It's one of the reasons I'm in human genetics. And even if you take ACTA2, there's, some people that get the strokes, there's other people that get early onset heart attacks due to the ACTA2 gene. And what's going on in terms of causing those different types of vascular diseases, we've been working on that for about 10 years now. Mm-hmm. And we're just publishing all that data this year, and it's really interesting. And you'll have to have me back sometime to talk to the actual people about it. Mm-hmm. It's unbelievably complicated, but it shows you how amazing the system is and how tight the controls are. Because we're talking about just a difference in one base pair,
sure,
one gene, and that's just one base pair out of 3 billion in the human genomes that suddenly predicts that you're going to have exactly these problems as you grow and get older. Mm-hmm. So it's the preciseness of the system is just amazing.
So a very insightful question that to the
very, very molecular, and all of you would fall asleep if I said.
Okay, so we're all gonna get some advanced training in molecular biology.
Yeah.
Okay. Getting back to the questions. This I think is a good one. I'm sure you've answered this 1,000 times, Dr. Milewicz, but who can benefit from genetic testing for heritable thoracic aortic disease? Period. That's the question. Who should seek that out, talk to a genetic counselor or geneticist, or seek a referral for that?
So if you've had 2 or more members in your family with thoracic aortic aneurysms and or dissections, definitely talk to your physician about it. You should undergo imaging, and if you have an aneurysm, then they can do the genetic testing on you. But if you don't have an aneurysm, you would want to do the genetic testing for your family on somebody who's definitely affected. And so that may be your uncle, your, great aunt or something, somebody who had an aneurysm repaired 20 years ago. But you have to go to somebody that definitely has the disease to be tested. And so that's one case. If you have all the features of Marfan syndrome or low states, also get tested. Absolutely. Whether there's a history, if there's enough features and you have aortic enlargement, then yes, get tested. Anybody who's showing up really young with disease, and we don't have a definite number for aneurysm formation. I think right now all children that walk in with aneurysms are being tested. But what the age cutoff where the yield is low, we don't know. We do know for dissections, if we take somebody under the age of 60 who's come in with a dissection, 10% of them will have an alteration in one of those genes. So we do recommend that if you dissected, even without a family history, if you dissected under the age of 60, have genetic testing. And we may push that up to anybody who dissects once we have a little more data.
Okay. And just to add a little comment, because someone specifically asked about someone who unfortunately passed away due to dissection. In many cases, there may be a sample that was stored by the medical examiner if the person had an autopsy done, and they will often keep it for years following the death. So it is possible to do genetic testing post-mortem or after death for someone. So if someone fits in that category, died at a young age from a dissection, that may be something that...
Right. So they may keep a blood sample at the time of autopsy. If the individual had any surgery, they may still have tissue left over from that surgery in the pathology lab or in the medical examiner's lab. And we can get DNA from those pieces of tissue also for genetic testing.
So I hope that's helpful to the person in the comment there whose wife passed away with dissection.
Yeah, I'm sorry.
Okay, so someone's asking about, let's see here, how to find your genetic testing. I hope either Bella or Meredith, if you could put up the info about from our website about how to access finding a geneticist or a genetic counselor or getting a referral from your primary care provider, that would be great. Someone just wanted to clarify, they thought you might have said statin instead of losartan, but you were talking about losartan, not statin.
Yeah.
Okay. Thank you to Meredith or whomever did that, putting up that sign for us. Someone's asking about genetic testing and life insurance. And we are going to be speaking with a genetic counselor later this year who will be able to get to some of these nitty-gritty details. But that may, do you want to comment on that, Dr. Milewicz, just to say?
Yeah, what we recommend in our clinic is that that if you have like a family mutation running in your family and you want to check yourself or your children and you haven't had an echo and you're not known to have aortic disease, to go ahead and get life insurance and disability insurance and so on before you do the genetic testing. So for health insurance, they cannot discriminate against you if you have a positive genetic testing result, but you don't have an aneurysm yet. They still have to provide insurance. But the other type of insurance, they can take that into account and it will raise the cost of getting that insurance.
Fantastic. And just to note, of course, we are in the United States, so if we have any Canadian or outside listeners, it may vary in your country.
I think the same is true in Canada, but I
just had no idea, so I didn't want to say.
I mean, everybody has health healthcare,
Sure.
but
Yeah.
the insurance, the other types of insurance, I think they can still discriminate.
If you are Canadian and need help with that, we can connect you with our sister organization that operates in Canada. So feel free to send us an email if you need that advice. Okay. This is not genetics, but you were talking a lot about blood pressure. So someone asked about blood pressure control and what is the level that we want to stay under. When you say, take our beta blockers, maybe we'll learn from Dr. Prakash later this month about exercising to bring our blood pressure down. What's the goal that we're trying to stay under with hypertension?
120/80. And I would say if I had an aneurysm or a genetic risk for thoracic aortic disease, I would try for like 110/70 to keep it around there. I personally have hypertension, and I try to keep my blood pressure around 110/70. And that's because there's now huge epidemiology studies that if they look at people's blood pressure and their risk for dementia, every 10 points of that first number that it goes up, your risk for Alzheimer's and other dementias goes up. So if you keep your blood pressure at 130/90, it goes up versus 120/80, and the same thing with every 10 points up. And so they didn't look under 120/80 to see if it went down still further, but just based on that, I try to keep my blood pressure around 110/70.
Okay, so do as the doctor says and does in this case.
Yes, yes.
Okay, so we had someone write in, they have a familial ACTA2 mutation. You sort of addressed this last time, but can never say it too much. They tested negative for it. Their kids, do they need to be tested?
No.
No.
Okay. So we talked, should I go back through this?
Yeah, it can't be hit enough. I think this is a hard concept for people to understand, especially with the skipped generation that kind of is in colloquial everyday talk. And we can see it in our families with other conditions. So it's hard to kind of put together, I think.
Yeah. So we all have 2 copies of the ACTA2 gene, and we get 1 copy from mom and 1 from dad. And somebody that has an ACTA2 alteration will have 1 of those copies altered. And that's that mutation or pathogenic variant we talked about. And so when they go to have their kids, they have a 50-50 chance of passing it on to every child they have. It's like flipping a coin, and it's the same risk, it's the same probability as to whether you're going to have a boy or a girl and so on. It's just 50-50, and it's completely by chance. So if they pass on the normal one and get presumably a normal one from the other parent, the child does not have disease, and they cannot pass it on to their children. So if you have not gotten that familial change, you've got 2 normal ACTA2 genes. You can't not pass on the familial change to your children. But if you did get it, then you have a 50-50 risk of passing it on to your children.
Clear. So maybe we'll cut out that clip, and or maybe we'll film you specifically saying that, because it is probably the most common thing, or a version of that that I get from folks.
And the vast majority of the genes are not on the X chromosome, so they're on other chromosomes. So whether you get it or not is not dependent on your sex, whether you're male or female. So in families, it can look like that the women are at a decreased risk, because on average, the men will have aortic disease earlier and have dissections earlier than the women for most of the genes, for many of the genes. And that tends to be true in the general population, but it doesn't mean that the women aren't at risk. They're still at risk. We had one family where the mother had no aortic enlargement until her 80s, but both of her children, both a boy and a girl, had dissections in their 30s.
Mhm.
So despite the fact she looked like she had no disease, she still passed it on to her children, and they went on to have disease much earlier than her.
Mhm.
So
So I think that's a really good example to when people think about skipping a generation, it's not really skipping anyone. She carried it. She just didn't have the actual outcome, but she still carried that genetic change. So,
and
really,
she did have an aneurysm, and she ended up having a dissection at 84 on a very small aneurysm. So, yeah.
okay. Okay, hopefully that is helpful for everyone. How often should you have genetic testing? I think I mentioned a little earlier today that you should follow up if it's been a number of years, but is there, your laboratory is of course discovering or identifying, rather, I should say, these new genes all the time. So is it a every year thing, every 10 years?
I'd say 5 to 6 years. Talk to your doctor about it.
Okay.
I'm hoping, we have all these new technologies like artificial intelligence, machine learning. We're learning more about the triggers for dissections that probably will tell us more about the genetic risks, those molecular pathogenic changes. So I'm hoping that in the next 10 years, we can make a big jump and have a much better understanding of the genetics. But right now we're moving faster than we did 10 years ago, but it's still slow finding new genes.
Mm-hmm, mm-hmm. Okay.
Remember, we're by and large looking for one base pair change and 3 billion base pair changes that's triggering the disease in the unsolved families.
A tough scavenger hunt for sure.
Yeah, and there's so many genes that can cause this disease, so it becomes it's not easy.
With respect to genetic testing, someone asked about groups like 23andMe and Ancestry, which people tend to do for finding out, what their ethnicity is or long lost cousins and those types of things. So maybe you could just quickly, we don't want to, of course, get into the weeds too much, but comment on how that's different from what we're talking about now.
So for 23andMe and all the Ancestry.com and so on, what they're doing is they're not looking for those rare pathogenic variants or mutations. They're scanning your genome for common variants. And those common variants will tell you what your ancestry is. It'll allow them, if they have a huge database, to say, oh, you've got a first cousin here, or, a distant relative here. And it does help to inform some risk for disease, but I think most of the data still says that if you just look at your family and what's running in your family, it tells you more information at this point than the 23andMe or Ancestry.com type of genetic testing. But I think over time that'll get better, but it is not the same test that they do when they're screening for genes causing aneurysms and dissections to be inherited in families. It's a completely different type of genetic test.
That's very helpful. And some folks are chatting about, how it can be hard to access genetic testing. Sometimes your doctor doesn't want to order it. I'm just going to add a little link in the chat to the genetics page on our website, which kind of shows you some different resources, including a few that you can do virtually through these clinical testing laboratories that are the same ones that you would get if you went to a doctor's office.
Yeah, so there's a couple of the genetic testing labs where we send our patient samples to that will do direct-to-consumer testing. So you can order the test, they'll send you the kit to spit into, and they will provide genetic counseling if it comes back positive and help you understand the results. I still think it's better to go through a physician, but that is completely a valid way to get testing. Once again, if you're going to do that, you have to have somebody who's definitely affected in your family tested. Mm-hmm. And they would spit into the tube, you sieve the tube, you send it to them. It takes usually 4 to 6 weeks to get the results back, and they would report those results to you. And also, before they do the testing, they will tell you exactly what the cost is for the test. And they certainly have protocols that if you make less than a certain amount per year, that the cost to you goes down. I mean,
that, yeah, they do have great financial programs, and will take your insurance too, if you have medical insurance. So check those out. Of course, they're not affiliated with John Ritter Foundation, just as a disclaimer. They're just companies that offer this service.
And I have no financial, we find the genes, and about more than half, the majority of genes on the testing panel, we found, and I found, my research program found them, but we get no financial benefit. No, I don't, you can't patent a gene, so that's why we get no benefit. I do wish the companies would pay back and help us find the rest of the genes and help us in that way, financially, or just by referring the unsolved families back to us routinely, which some of them do.
A quick follow-up, when you mentioned that men sometimes tend to have an earlier age of onset than women, someone asked, is this because they tend to have higher blood pressure than women? Is that just kind of a lifestyle reason for it, or is it some other reason?
We don't know why. And the gene can, and it can vary from gene to gene, and we really don't understand this at all. And it's something that needs to be worked on through research. And some of the differences are really interesting, like TGFBR1 and TGFBR2 encode for proteins that actually interact with each other directly. And TGFBR2, there's no difference between age of onset of men and women. But with TGFBR1, there's significant differences, with men having dissections in their 20s and 30s, and only by the age of 60, only like 50% of the women have had an aneurysm or a dissection repaired. So it's really dramatic.
A lot more work for you to do.
Not for me. There's a lot of other research. I'm focused on finding the triggers for dissection and trying to find the rest of the genes for dissection. Familial disease.
Well, I think that's a pretty good place to end here, because we've taken an hour of your time. But some folks emailed me asking about, if they're in your research, how can they hear about what's going on and get an update maybe, or maybe if they have something new to share with you all about someone new who's been diagnosed. So please contact research.
Yeah, Bella, if you can go ahead and put into the chat the email to get you. Isabella Marin is the research nurse that Meredith put it in there. It's jrrp.research@uth.tmc.edu. And Bella is there. She's on the chat now. She should turn the camera on. She's the research nurse that is working with all the families to get them recruited, and families that were recruited years ago to get them updated. And so she's the person that when you email jrrp.research, she's the person that will be answering the email. And she's fabulous.
She's the best. And I know many of you know me from when I was there, but unfortunately I can no longer give you those updates. So please Bella directly.
And
you worked with me fast.
I think it's been, we do send out emails about events like aortic dissection awareness to the people that are participating in our research. And we do send out emails, a newsletter, but we don't get to it very often. It takes a lot of work to put together. Believe it or not, we're not people.
We prefer you to be focused on identifying those genes and figuring out how to prevent dissection.
Yeah, we're really busy with the research and trying to keep that on track.
And we love that you are. Thank you so much. Personally, thank you for being here. I always love learning from you and hearing from you. And then thank you, for the community and the John Ritter Foundation as well, because I know everyone learns so much whenever you are here to share your info with us. And that will be posted online. And I should have mentioned earlier, Dr. Siddharth Prakash, who Dr. Milewicz mentioned at her presentation, who does a lot of research on aortic disease And exercise is going to be our speaker this month. A ton of you had questions about exercise, so we were able to pin him down for June. So be sure to join us with those questions you had about exercise.
Yes, he's one of the world's experts in this area, and it's such an important question. And like I said, it's a major area of research that we have to do more work on. And Aortic is leading the charge. Thank you, Ellen. Good job with the questions, as always. And thank you, everybody, for joining us.
Yeah, thanks, everyone. Take care. We'll see you next time.
Bye. Bye, Meredith. Bye, Bella. Bye, Ellen. Good job.